Now, scleroderma. I feel so bad for scleroderma patients, as I'm sure you do, especially diffuse scleroderma. So early on in my career, I was really, really fortunate because I practiced at a very large institution, Northwestern in Chicago, that had a scleroderma clinic. And I actually will never forget this thing. So we had this really great scleroderma expert. His name is Dr. John Barga. Like, if you look up to date and you kind of scleroderma, like, he's the author for a lot of these things. And I'm sitting in the room. Okay, first of all, in the first APP in general rheumatology there, which, as if anyone's done the first APP in a specialty, I have done it a few times now. Not maybe because I wanted to, but because of just situation. It's challenging, right? You like to be the first one, right? Because you're in there, you're trying to teach them. And I also get it from their perspective too. Like, they don't know what we know. They don't know, so it's building trust, right? So anyways, I'm in the doc box and with the rest of them. And, I don't even remember what I was doing there, but I'm sitting there and he starts talking about scleroderma because he's this scleroderma, world-renowned expert. And he's talking to, I don't know if he's talking to some med students or residents or whatever, but he's talking about GAVE, which is basically where they get these telangiectasias within, their belly. And so he's talking about that and he's like, can someone tell me about, GAVE or whatever? And it's radio silence. And I'm looking and I'm I can answer that question. And so he's like, who are you? And so I'm Amanda, your PA that's here, And there's this awkward silence of what's a PA, and so bless the man. God bless. He's so incredible. But I was like, well, you guys have a PA school here. But anyways, what that led to is then all of a sudden he was like, wait a second, you know about scleroderma? And because I had already practiced in rheumatology prior to going to Northwestern, and I'm like, yes, I know about scleroderma. I've managed scleroderma. And then all of a sudden I found myself in the middle of the scleroderma clinic, seeing people that are losing fingers. And I was like, I didn't want this. So I found myself having to really help to manage, a lot of really sick patients. And, oftentimes because none of the rheumatologists wanted to work on Fridays and I was always there on Fridays. So then I'm seeing these people that are about to lose a finger or but I learned, right? That's a one day. I learned so much about scleroderma, way more than I ever thought about diffuse scleroderma. And that was such an incredible experience because I left and I wasn't at Northwestern for very long. I'm from Michigan. I went to Colorado. My husband got into pharmacy school there. So we went there. Then he did a residency. So went to Chicago. That's what led us there. But after a month, I grew up in Michigan. I thought I knew the cold. But I'm that was a whole new kind of cold. And so after we were there for a year and after that, we decided to come back to Colorado where, believe it or not, the weather's really, really nice. So, but I was I came back so equipped. I was I can treat anything associated with scleroderma. And so anyways, I do still have a lot of scleroderma patients. But again, that year I think really, really taught me, which I think is why I would just encourage everyone, don't be afraid to treat the really sick patients. It's how you learn and it's how you become confident and have the ability to continue to do it. And so I do not shy away from vasculitis or diffuse scleroderma. Yes. Could I hand those patients off? Of course. I had a really amazing collaborating physician. I don't share any patients with him, but if I did feel like I needed to, I'm sure I could give them. But I don't because I want to learn. I want to understand. And with that confidence, we can really treat any manifestation, any disease process. You just have to understand how to do it, obviously, so that it's safe for the patients. And I think we all understand what our own limitations are. But anyways, so diffuse scleroderma is where basically you have the skin involvement that goes proximal to the elbows and the knees, right? So these patients will have skin tightness that goes into their legs, their chest, their trunk, their face, their neck. They usually have a reduced oral aperture. So you ask them to open their mouths and they can't really do it very well. You'll see telangiectasias, those little pinpoint dots. Often they'll have it on the roof of their mouth. They'll have that all over their, their face, their body. The ANA kind of can be tricky, but you might see a nucleolar pattern. You could see speckled pattern. But that's kind of, diffuse scleroderma. It's basically, you have to think about it as this inflammatory process, this fibrosis that's happening, just like it happened in the lungs, under the skin. And so their skin becomes very shiny, very thick. So if people can't sometimes even, go like this because they're very, everyone's seen all right, so this purpose. So you kind of know it when you see it. It's associated with positive SCL70 antibodies. So that's kind of what can differentiate it from like limited scleroderma and also RNA polymerase 3 antibodies. I want that to be in your brains too, because that's important. That is, that's not good when you see RNA polymerase 3, as again, you probably already know, but those patients, higher mortality rate, higher ILD, higher a risk of something called Scleroderma Renal Crisis, which I will touch on in a moment. Usually though, and this is something that you can tell your patients, like you see a new ILD patient because they come to you before they get to rheumatology. That thickness, because it can be really scary. I mean, it can happen. I will tell you, I had a patient who had seen a different rheumatologist, and that rheumatologist had said, you have osteoarthritis in your hands. So was referred then to orthopedics, who said, I don't think that this is just all, osteoarthritis. So then encouraged them to get a second opinion. So then I was the second opinion. And I saw this patient and I'm like, oh, this doesn't look good. Like she had the startus there. It was very clear to me. Do I think that the initial rheumatologist got it wrong? No, not at all. Because it can be like a very fast progression of the skin thickening. And I will tell you, within just a few weeks to months, her skin thickening actually got markedly worse. It was one of actually the fastest patients that I had seen. Also had early ILD. I mean, it was like every manifestation you kind of read about in the books, this patient started to experience. Fortunately, she got into a CAR T therapy clinical trial, and I hadn't seen her actually, but I heard that because also with like diffuse scleroderma, if you have a scleroderma center, like I send them down to see you, to see some of the scleroderma experts, particularly if they're diffuse, just because I feel like there's clinical trials, etc. I really would like them to also take a look and make sure, that, we're doing everything, I'm doing everything correctly. And I haven't seen her back, but I heard from the rheumatologist, there's also a friend of mine that runs this scleroderma center down at the university, that she was doing remarkably well. So, it was so encouraging just to know, like, that I was able to like help her along this journey. Whereas, I think perhaps she felt like she was blown up before. So, But you can tell people usually it happens 1 to 3 years and then it really does slow down. So it's not like they're going to just be stuck, I mean, it does tend to slow down after they've had the disease. And usually the onset, Raynaud is always going to be the very first manifestation. And that's usually within 1 year of the skin involvement. Obviously, these patients are sicker. Like these are the people that I saw at Northwestern where they were all diffuse scleroderma. And again, they can develop early on ILD, renal failure, GI, heart, I mean, basically everything. So if you suspect a patient has really diffuse, I mean, any kind of scleroderma, but diffuse, these people really need care ASAP. And it is more prevalent. The ILD part of it is more prevalent in males and African Americans. So again, this is what it kind of can look like. They get the Raynaud, this progressive skin thickening. You might, I don't know what you've been doing those, but they can get tendon friction rubs that you can kind of feel in their hands. They will all have some kind of GI involvement, which makes your job much harder because then they get the reflux and they have their esophaguses are usually pretty tight and narrow. They can have arthritis. That happens usually, like I said, within the first year. Year 1 to 5 is really when these people get interstitial lung disease as well as Scleroderma Renal Crisis. And Scleroderma Renal Crisis, has anybody seen it? Has anybody had it happen? Okay, so Scleroderma renal crisis is definitely not something you want to miss. This happens in diffuse scleroderma. So do you remember when I said I got back from Northwestern, like feeling like I could just manage anything that had to do with scleroderma? Well, I saw this gentleman and he had kind of like puppy hands. And he kind of came already on some steroids in my defense. But I was like, okay, yeah, it's probably rheumatoid arthritis. His mom had RA. So I kind of go down the road. And then maybe he needed a little more steroids and kind of like working him up. And then all of a sudden, he ends up in the emergency department. His blood pressure shot through the roof. And as they were doing kind of the workup as he was admitted, he had already polymerase. I completely had the wrong diagnosis. He had diffuse, the start of diffuse scleroderma and developed scleroderma renal crisis, which I made worse. And so I say all of that to say, I tell that story almost every time I do a lecture because I think it's important also to understand our that we all make mistakes. We just have to learn from them. And so I really try to make darn sure I know what I'm doing, but it's associated with steroid use. And so, and basically, again, their blood pressures, that's how we check blood pressures all the time. But if you have a diffuse scleroderma patient and, they're usually the blood pressure is pretty good and all of a sudden it spikes, you really have to think about this. Again, it's an earlier manifestation, but again, something to think about. All of a sudden the blood pressure shoot, which we'd be managing anyways, right? Like we'd be getting an acute evaluation for that. But that's just one of those things that is not good because if they don't get treatment really fast, it can lead to renal failure. So pretty significant.